Thank you for the opportunity to come and talk today. And it's really great to have TB on the program. And TB is becoming quite a challenge for us, but I totally acknowledge it's a low burden disease, and we are so grateful for the support of so many people here who help support our TB patients. So I was asked to talk about what's new in TB, and until a few years ago this talk would have been really short, and so then I suddenly realised I had quite a lot of slides, so we'll go through them quite quickly. But there have been quite a few interesting new changes in the world of TB over recent years. You might have seen in the Herald just a couple of days ago the headline about the TB surge. There is significant international concern that COVID overtook TB for a while, but actually now TB is surging again. And TB programs internationally have been significantly undermined by the COVID epidemic, and a lot of the public health support for TB has been utilised to support COVID programs. There's areas of world conflict as well where there's significant TB numbers. So in 2021, and TB data always lags behind by a couple of years, globally there was about 10 million people who fell ill with TB, and 1.6 million of those people actually died from TB. But concerningly in 2021 was that the TB incidence globally actually rose by about 3.6%, which sounds like a little, but when you put it into the context, up until that time, we'd been having a 2% fall every year. And so this is the first time that there's been a surge, and there's a huge concern about what's happened in the last few years. We've had an increase in the burden of drug-resistant TB. When I say RR-TB, I'm talking about rifampicin-resistant or even multi-drug resistant TB. And it said that about 60% treatment success globally for drug-resistant TB, so that remains a real concern that there's a huge number of cases that haven't been adequately treated who act as a source for ongoing transmission. In New Zealand, our numbers had been relatively static, around 300, 320. I think in 2021 it was actually reported at 350 cases in New Zealand, so really low numbers still. Overrepresentation in the Asian ethnic group, in the Mila group, in the Pacific peoples. Although the majority of our patients are born outside of New Zealand, I think it's important to remember that just under 20%, so 1 in 5 of our cases is actually New Zealand born, and we still have transmission within New Zealand. The other thing that I think is important to highlight is that for people born outside New Zealand, immigrating is really stressful. It's a time of significant change. Often it can be a time of exposure to TB, but there's a significant risk of reactivating TB. So people who have latent TB, developing active TB disease in those first few years after arrival in New Zealand. And that continues for those first sort of 5 years of after people arrive in New Zealand with that higher risk, and then lowers but continues for many years after. So just to put up the natural history of TB that people will be familiar with, not everyone exposed to a case of TB becomes infected. Of those who develop infection, about 20 to 30% who become infected, most of those will go on to develop latent TB or sleeping TB and remain well and are not infectious to other people. And about 10% will go on to develop active TB, with half of those doing that within the first 2 years of exposure and half doing it many, many years later. And time since infection obviously influences that, age when infection occurs, and any significant predisposing medical condition, so any significant immunosuppression. So just looking at the latent TB group, just to highlight that we have, historically we've always treated these patients with isoniazid, but in the last few years with the new update to our national TB guideline since 2019, we've switched to very much treating patients with rifampicin. So this has been a massive change in that rifampicin tends to be much better tolerated. People are more likely to complete treatment. It's a shorter course, only 4 months. There are some challenges around drug interactions, which we try to carefully watch, but sometimes other drugs can sneak in when people are on rifampicin. It still can cause hepatotoxicity, but it's a much lower rate than for our isoniazid group. And just to highlight, this is an exciting trial. It's from a few years back now, and this is the Prevent TB trial, where actually 12 doses, so given a week apart, so 12 doses in total, a 3-month course using a rifapentine base. And the exciting thing about this trial was really good outcomes in preventing TB, much less pill burden, much easier to take. One of the challenges we've still got is we still don't have rifapentine in New Zealand, but we are working on this and hope that this might change in the coming years. So all of these treatments are considered to be equally efficacious, and our priority groups at the moment are really trying to make sure we've covered our highly immunosuppressed patients, our recent contacts who are much higher risk of developing active TB, and we also have been focusing on healthcare workers and trying to make sure that people who have a positive quantiferon or non-significant exposure have had some discussion around this. Moving on to talk about active TB, we've got a much better understanding of the risk factors that result in progression to active disease. So HIV remains at the top there with the highest risks, and transplantation and people on significant immunosuppression. But I think what's important to highlight, within our population, we have a very high rate of diabetes, and so there is a significant increase in risk for that group of patients. And we've known that diabetes and TB are a bad mix for a long time, so this is a nice article from 1934, but we've managed to define that better, and I like this because there are usually fairly small numbers in TB studies, but this was 1.7 million participants, and we showed that it was shown that there was a significant increase for our diabetic population. So we screen all our TB patients for diabetes, and we screen them all for HIV infection. Biologics have also had a really significant impact on TB reactivation, and just something to be aware of. It's often actually harder to screen this group of patients because they're often already quite immunosuppressed from their underlying disease. Not all TB presents with this classic chest X-ray, and we talk about our usual symptoms of TB, but just to highlight that about a third of the cases that we see are actually diagnosed after a presentation for a completely unrelated complaint. So most people that we're seeing in our TB, or a third of the people we see in our TB clinic, are relatively asymptomatic. So across the top, we've got some of the chest X-rays with nodal disease, pleural effusion, and a case of miliary TB. But just to highlight that TB occurs at any site, so osteomyelitis, septic arthritis. In the middle, we've got Bazin's disease, which is TB of the skin, gastrointestinal tract, someone with spinal disease, psoas abscess, CNS disease, and pericardial disease. So the most important thing is maintaining a high index of suspicion. Just to highlight, we do have some better testing. We've got the Gene Expert, which gives us a quicker diagnosis around, is this patient got TB and have they got rifampicin resistance, which is a marker for drug-resistant TB, and that can be done directly on sputum, but we tend to use it for patients who are smear positive and once we've got a culture, and so we are potentially getting patients onto treatment much earlier. There's been quite a lot of advances in TB treatment, and so last year there was a flurry of new statements from WHO about treatment going forward. And just to highlight, there is now a new recommendation for WHO for a 4-month treatment regimen. So you can see from the 80s we really had no change in what we've done with this new recommendation, but again we're struggling because we don't have rifapentine here yet, but this is certainly going to improve things for our TB patients. So we still use our standard 6-month treatment for most TB patients. Adverse drug reactions remain a real problem for our patients. It's quite common to have some form of problem once patients start treatment, but about 10% have some serious adverse event or require a change in their treatment, with skin rash, hepatitis, eye problems and joint problems being our most common presentations of concern. Just to highlight on drug-resistant TB, I've already mentioned there remains this massive international challenge on this. There's a huge detection gap in these cases. There's a huge treatment gap and an outcome gap. And so globally, the success of these cases is low. This makes up a very small proportion of our cases in New Zealand, but these remain a major challenge with a huge amount of resource to treat these patients. We've got some new definitions around MDR, TB, MDR-TB stayed the same, sorry, it's resistance to isoniazid and rifampicin, but we've now got new definitions around pre-XDR and XDR-TB. There is some really exciting stuff happening in the world of drug-resistant TB with data and recommendations coming out about short course treatment. So historically we've treated these patients for 18 months, really difficult to take treatment, lots of side effects, and these new drugs are going to really change the way we approach this. Again, we don't have predominant, but we do have bedaquiline and linezolid, and so we are really excited about the potential to shorten treatment for these patients going forward. A few other challenges. Not uncommon after we start TB treatment that patients can get what we call a paradoxical reaction to treatment, where things can actually get worse before they get better. So sometimes fevers return, they get worsening respiratory symptoms. We always want to hear if people are concerned, so please just send us through a note. We do see some TB complications, and we certainly have a number of patients with significant bronchiectasis and fungal complications and long-term respiratory problems related to TB. And just to, as my last slide really, there are some challenges in understanding how TB services work in Auckland. And so just to highlight that all the pulmonary cases essentially goes to the respiratory service at Auckland City Hospital. All the extra-pulmonary cases who don't have pulmonary as well go to the infectious diseases services across the three hospitals, and anyone with HIV and TB, even if it's pulmonary, goes back to the ID service at Auckland. So it's very confusing for all of us, and if you're not sure, just send it through and we'll triage it to the right service. Key messages: high index of suspicion to diagnose, especially in our environment where we have such few cases. I think it's really important to keep it on the radar. We have quite a significant immunosuppressed population, and they often present more atypically with not the typical upper lobe changes. And hopefully we've got some shorter, better tolerated treatments on the horizon. Thank you.